Okay, all right. Good afternoon, everyone. Thank you all for attending our webinar on antipsychotic medications. This is going to be brought to you by Dr. William Kehoe. He's our clinical pharmacy consultant here at VMRC. So a little housekeeping for our webinar. I wanted to let you guys know, for those who want to claim CEUs for this webinar, instead of contacting Lorraine, you're going to be contacting Vicky Fisher. So her email is vfisher@vmrc.net. And Dr. Kehoe, please send her your quizzes as well, so that she could send it to the participants who are interested. So again, it's going to be Vicky Fisher. Her email is V as in Victory, FISHER@vmrc.net. And then we are recording this webinar. So once Zoom sends me the link, we will eventually post it to our VMRC website under the events tab and under clinical. It's also going to be at the VMRC YouTube page. Okay, so with that, I will give the floor to Dr. Kehoe.
Okay, thank you, Claire. Welcome, everyone, and I hope you're staying safe and healthy. I know right now we're experiencing a lot of COVID cases in our region, and I just wish you all the best and encourage you to remember to mask up and social distance and protect yourself, because it'll be a little while before we get out of this, but I'm very optimistic. Our vaccines are arriving, and at my hospital, healthcare staff are beginning to get them. So I just wanted to wish you all the best. Now, again, today, just to remind you, this module is being recorded, and as soon as Zoom returns it to Dr. Lazzaro, it'll be posted on the VMRC website, and you can view it. And this presentation does include some videos that I use from YouTube, and on the slides, the link is put on the slide. We'll just, when I get to those slides, I'm going to have to go out to get those videos, because I accidentally closed my browser, had them all queued up. But anyway, so this module does include continuing education credit. There's a small quiz that you'll have to take. And as you just heard, you'll send an email to Vicky Fisher at VMRC. She'll send you the quiz. You can send her the answers, or you can print the quiz and put your answers on it and scan it and send it back, whatever is easiest for you. Just the important point is just make sure that you let her know exactly how to send your certificate back to you. So I wanted to talk today mostly about antipsychotic medications, but before we get to that place, I wanted to mention a few things about psychotropic medications. One of the kind of unfortunate things about psychotropic medications is we tend to class them and to group them into classes with names like antipsychotics, antidepressants, agents like these that were originally used for a certain indication. So for instance, an antipsychotic obviously is used to treat psychosis. An antidepressant treats depression, but today we find multiple uses for these medications, and not always for the reason that you might infer from the name of the medication. So agents within a class, or specific agents, are approved by the FDA for what we call specific indications. What that means is the drug was tested in certain situations. So for instance, antipsychotics were tested in patients who had psychotic disorders like schizophrenia. The FDA reviewed those data and then approved them for those indications. And that doesn't mean that the medication can't be used for other reasons, and we call that an off-label use. As the medications are with us for a while, we learn that they might do some other things than just treat psychosis. So for instance, those of you who watch television and get all your good drug information there, you will see advertisements for some of the antipsychotics for patients who have depression, whether it's unipolar or bipolar depression. You'll see antipsychotics being advertised for that. And those are actually approved uses, but in the beginning, before those were reviewed by the FDA, those would have been called off-label uses. So always remember that just because a consumer is getting an antipsychotic medication does not actually mean that the consumer has a psychotic disorder. It could be for other reasons, mood stabilization, augmentation of an antidepressant, etc. Another thing to remember is that there's no medication ever anywhere that doesn't cause side effects, none. Even the medications that you go and you buy at the grocery store, over in the medication area that are over the counter, those medications can cause side effects. And that's certainly true with the antipsychotics that we're going to talk about today. Now, with these medications, there are some common side effects that we see, but you always have to remember that everyone's an individual. They react to the drug specifically, and people may experience a side effect that's rare or something that we really haven't seen. So they experience things differently. So we never want to rule out something just because it's not one of the side effects listed for that medication. Another thing to remember is that side effects from, or medication effects from some of these drugs can look like a psychiatric condition. So we're going to talk a little bit later about a side effect called akathisia. And that's a restlessness and the inability to sit still, patients pace, they seem somewhat anxious. That if that's not watched for, then it could look like the patient is simply anxious. So you have to be careful with some of these side effects and be aware, and then let us know if you see some of these things happening. And another thing to remember about psychotropic medications is that they are generally not curative. They control the symptoms, but in general, they don't cure. Now, what that means is that for many of the indications that we use psychotropic drugs, patients will be on these for a very long period of time. Now, sometimes, for instance, with antidepressants, if it's the first depressive episode, after 9 to 12 months, we might try the patient off of it. If they never have another episode, great. But if they have another episode, we'll put them back on the medication and they'll probably stay on it for a long time. We also know a lot about the pharmacology of these agents, but that doesn't mean that we know ultimately how they're actually producing their effect on these disorders. And so the drugs we're going to talk about today, the antipsychotics, first generation and second generation, we know the pharmacology reasonably well, but that doesn't mean that we know how these pharmacologic effects really impact the disorders that we're talking about. We have some ideas, but we're seeing new classes of drugs developed all the time that act in different ways than these medications. So we're making a lot of progress in the different kinds of psychotropic medications that we have for our patients. Now, some other things to remember is that many medications, psychotropics, can cause psychiatric side effects. So we have to keep that in mind. Another thing to remember is that we often use, excuse me, combinations of psychotropic medications. And I find this to be especially true among our VMRC consumers. Many of them have developmental disorders and things like going on that can make treatment of some of these conditions more difficult. And it's not unusual to see our consumers on more than one psychotropic medication. What that means is we have to watch them more closely. Some side effects are additive. So for instance, many of these drugs by themselves might cause constipation or dry mouth. And if you combine drugs with those properties, you might be more likely to see those side effects. So it's very important when we have consumers that are on combinations of these agents that we're watching them for side effects. Another thing to remember is that some VMRC consumers actually, they're living independently, and we try to keep them in the least restrictive environment that we can. And that means some of them may have access to and use illicit substances. and those might have psychological effects. So we have to be aware of that and watch for it when we need to. Now, another group that produces challenges for us are the elderly consumers. Older people tend to have more problems with psychotropic medications than younger patients do. And there are a number of physiologic reasons for this. But what it means is we have to be really careful using these medications in the elderly. Now, what is the elderly? That always comes up when I teach students. They're, well, what's elderly? Obviously, I'm one of those. But we generally talk about 60, 65 and above, somewhere in that range, depending on who you talk to, usually 65. Now, remember, again, that with some of our consumers, even at a younger age, because of the multiple conditions that they may have, they may be more sensitive also to some of the problems that we see with psychotropic medications. The last thing I want to point out is that we don't use psychotropic medications as a form of restraint. We do use these medications in order to manage some of the symptoms that our consumers show, but we do not use them simply to make life easier for the caregivers and those sorts of things. So they're never really considered a form of chemical restraint. So let's be a little bit more specific now and talk about antipsychotic medications. As I said, these drugs were originally developed to treat psychosis, and they were found somewhat serendipitously and being investigated for other reasons, and then turned out to actually be effective for psychotic disorders. And it really did change the treatment of mental disorders, and particularly psychosis, like schizophrenia and those sorts of things. Now, psychosis, what do we mean by that? It's a term that's thrown around a lot. You'll see it just tossed out there by people who may or may not know what it really means. And psychosis involves either hallucinations and or delusions. Now, what is a hallucination? A hallucination is a sensory experience. So for instance, you see something that's not there. You hear something that's not there, like voices. Or it can involve any sensory system. You can smell things or taste things. But with the disorders we're talking about, the most common types would be sensory, including seeing things or hearing voices. Now, what are delusions? Those are incorrect, false beliefs. And those are relatively fixed. So a person might tell you, for instance, I am being chased by the CIA or whatever, and those are demonstrably false, but nevertheless they believe that, and so that's what's called a delusion. Now, since we started using these medications and we became more familiar with them, we found that some of these agents actually work for other conditions. And that's particularly true of what we call second generation antipsychotics. I'll tell you what those are in a moment, but it simply means the newer antipsychotics that we have available to us. And we found that they work for other conditions, for instance, bipolar disorder, both manic episodes and depressive episodes. And they work for depression and are often used in combination with an antidepressant for a patient whose symptoms haven't entirely cleared with the antidepressant by itself. And as I said, there are several off-label uses. And again, that simply means that it's used for a condition that no one has done the clinical trials to submit to the FDA to get the FDA approval for using it for that condition. So in general, there are a couple of ways of looking at or naming these antipsychotics. The older ones, you can simply call them older ones. We typically call them first generation or conventional antipsychotics. And those are the ones that you might be somewhat familiar with. Haloperidol, the brand name is Haldol. Chlorpromazine is the brand name is Thorazine, et cetera. So there were a whole host of those drugs that were developed. And some of them come from different chemical classes, but they were developed by the medicinal chemists and the pharmacologists, knowing that primarily their impact in terms of effectiveness was by blocking certain subsets of dopamine receptors. And so the pharmacologists and the medicinal chemists could come along and develop new agents. So you ended up with a whole host of these medications. Many of them are still used and are very commonly used. Some of them have fallen by the wayside and you rarely see them, or they've been discontinued. Now, the other category is what we call second generation atypical or newer antipsychotics. These have become very popular and very commonly used. And again, you will see these advertised on television. Things, like risperidone, the brand name is Risperdal. Aripiprazole, the brand name is Abilify. So there's a whole host of these, and there are new ones in the pipeline coming along all the time. So in general, again, first generation versus second generation antipsychotics. Here's a little bit of the history. Chlorpromazine was developed and put into use in 1952. Following that, several other of what we call first generation antipsychotics were developed in the 60s. In the early 80s, he came up with what we're calling the newest or the first atypical or second generation antipsychotic, and that's Clozapine, followed by a whole host of other antipsychotics over, I would say, the last 20 to 25, 30 years. So what do we mean again by the first generation? Well, these again were the first medications found to be effective for psychosis. And as I said, they made a major change in the way we treated mental illness. Prior to that, there were not really very many effective medication modalities for psychotic disorders. And many of these patients were institutionalized for long periods of time. And then when chlorpromazine, brand name Thorazine, became available, it really changed treatment, allowed many people to be community dwelling and do much better so that they didn't have to go into an institution. And again, as I said, it was found sort of serendipitously because it was being looked at for other uses. So once that medication became available, they studied it, they found the pharmacology, and they began to develop the family of medications that I showed you. So this was a milestone in the medication treatment of mental illness. Now, how do these things work? The first generation antipsychotics, their primary therapeutic effect is to block dopamine receptors in the brain. And that leads to a reduction in psychosis. Now, that can also impact, as I said, problems with other disorders. So for instance, it might reduce mania if you have bipolar disorder and other things that we can use these drugs for. As we used them and became familiar with them, we saw that there were different kinds of side effects that we had to be aware of and actually limited the ability of patients to tolerate some of these medications. One of the more common problems that we see are movement problems. There are things that we call extrapyramidal side effects, and those are movement disorders, or Parkinsonism, which patients begin to look like they have Parkinson's disease, but it's actually a drug-induced situation where they get stiff, difficult walking. I've mentioned akathisia, which is, again, is this sort of inner restlessness and inability to sit still and must keep moving and sort of turmoil on the inside. And the last one on that list, Tardive Dyskinesia, is a long-term side effect of these drugs, and it causes abnormal involuntary movements. It can be anywhere in the body, but it's often in the upper area, the upper chest or thorax and in the head. Can be lip smacking. I'm going to show you some pictures of this later on, because that's what we use the Ames scale for, which is the abnormal involuntary movement scale. And the reason I want you to be aware of that is that the longer we use these medications, the higher the risk is of developing tardive dyskinesia. And we want to intervene early if we can, because tardive dyskinesia can be irreversible. And particularly if we don't catch it early enough, and it goes on, then it could be more difficult to control. So we're going to talk more about that later, but it's important that you start noticing if consumers have any kind of abnormal movement. Now, another important class of side effects are what we call anticholinergic side effects. And what that means is these drugs have the ability to block receptors for acetylcholine. Those things are important. Acetylcholinergic neurons are important for things like being able to salivate and gastrointestinal propulsion. If you block those things, you can get dry mouth and you can get constipation. You can get also dry eyes and some things like that. And that's important in our consumer population because many of them are already at risk for things like constipation because they may be sedentary in their lifestyle. They may be on multiple medications that can cause constipation. So we have to be careful with these drugs. And it's nice that some of them are less likely to cause this than other agents. We can change things around if it becomes a real problem. But I mentioned the drug Clozapine a moment ago, and constipation can be a very serious issue with Clozapine. And we actually need to think about it ahead of time if we're going to use that medication. These things can also have cardiovascular effects. They can drop your blood pressure, which is hypotension, and they can cause some conduction problems in the heart. You know, your heart has an electrical system, and these electrical impulses go and cause the atria and the ventricles to contract. And these medications can cause alterations in the conduction of those electrical impulses. Finally, sedation is another important aspect with these drugs. Again, consumers may be at higher risk of having a problem with this because they're often on multiple medications that can cause sedation. I reviewed a consumer's meds last week, and the list was really long, and this person had very difficult to control seizures. So she was on a number of anticonvulsant medications that can be quite sedating. And you put that in combination with some of these psychotropics, like some of the antipsychotics, and that can make sedation even more likely. So this is just a picture that I found to kind of give you a mental image of what these medications are doing. You have a neuron that comes together, and they come together kind of like this. One end is called the presynaptic end, and that's where the electrical impulse is coming down. And then you have at the end of that nerve there, the axon is a membrane, and the neurotransmitter is released as the electrical impulse comes to it. The neurotransmitter goes across that gap that we call the synapse, and then it approaches the postsynaptic neuron where the receptor is, and that's what those little boxes are on the end that's on the right side of that diagram. And what the antipsychotics do is they come along and they sit in that receptor and they block it for dopamine. And the therapeutic impact of that is that it can reduce psychosis. Non-therapeutic impact of that is that in areas of the brain that control motor movement, blocking those dopamine receptors can lead to movement abnormalities. And so that's just a part of what you get when you have a drug that blocks dopamine. Now, what do we mean by second generation antipsychotics? It became clear that dopamine is not the only neurotransmitter involved in the manifestations of schizophrenia. And in fact, serotonin also plays a role. It appears that serotonin may have a mediating effect on nerves that are primarily using dopamine. And so it turns out that these drugs have some advantages over the older agents. They cause fewer of these movement side effects, like extrapyramidal side effects. They have a lower risk of tardive dyskinesia. And there's some information, it's a little controversial. Most people feel that they might have a better impact on what we call the negative symptoms of schizophrenia, the withdrawal, the isolation, and some of those kinds of things. That's become a little controversial in recent years. But the one thing that I do see in our patients is that they do cause fewer of these movement problems and lower risk of tardive dyskinesia. Now, for first generation agents, they were difficult for many patients to stay on. And they're not used as commonly, although I still see plenty of patients at our hospital who are on these first generation drugs. But it's been difficult for many patients to tolerate these. And in general, second generations appear to be a little bit better tolerated, with the potential exception of metabolic side effects that I'll tell you about more about in just a few moments. So as a result of that, the medicinal chemists and pharmacologists have been on a quest to find newer agents that are equally effective, if not more effective, and better tolerated by our patients. So let's go back now and talk about what we use these medications for. Obviously, we use them for psychotic disorders like schizophrenia. But remember, psychosis can be seen with other things than schizophrenia. Psychosis can be seen with manic episodes of bipolar disorder, other things like schizoaffective disorder. There's even depression with psychotic features. So any place where you would see psychosis, you can use these medications. There are some specific uses for autism, agitation, and some of those kinds of things that you can see them used for. They don't treat autism, but they treat some of the symptoms that you might see. They're also used for Tourette's disorder. If you're not familiar with that, Tourette's disorder is a tic disorder, and those can be either motor tics, where there's little ticky movements, or vocal tics, and they work for that. They also are used to augment antidepressant medications. And this is why you see a lot of those television commercials where you'll see them say, you know, here's so-and-so, and she's been on an antidepressant, but not all of her symptoms have cleared. She should talk to her doctor about, and then you'll see that they talk about one of these antipsychotic medications and adding it to the antidepressant. We don't use them by themselves for depression, but we use them as what we call augmenting agents with the antidepressants. Some of these drugs have also been used to treat nausea and vomiting. And one in particular, chlorpromazine, the first one on the block, is used sometimes to treat migraine headaches, particularly in the emergency room, when an injectable agent is going to be used. So there are a number of uses for these medications, and we see those also in some of our consumers. So let me see if I can bring up this YouTube for you. I apologize. I had these all queued up and then I accidentally closed my browser. So let's go over here.
Hello, my name is Rory Sheehan, and I'm a psychiatrist and medical researcher at University College London. Together with colleagues, I have conducted a study investigating mental illness, challenging behaviour, and psychotropic drug use in people with intellectual disability. People with intellectual disability have impairment of intellectual functioning, along with difficulties in one or more life skills. They have an increased risk of developing a wide range of mental disorders, including severe mental illnesses such as schizophrenia. People with intellectual disability may also show challenging behaviour. This refers to any behaviour that puts the safety of the person or others at risk, or limits their involvement with community activities. Psychotropic drugs, which are designed to treat mental illness, might be overused in people with intellectual disability. There is particular concern that one group of these drugs, the antipsychotics, are often used to manage challenging behaviour. In order to investigate this possibility, we used data from the Health Improvement Network, a UK database of anonymised GP records that includes several million people. We identified over 33,000 adults with intellectual disability and followed them up for an average of 5.5 years, looking for records of mental illness, challenging behaviour, and prescription of psychotropic drugs. Overall, almost 2/3 had been prescribed psychotropic drugs, but only around 1/3 had a record of mental illness. people with challenging behavior were more than twice as likely to be prescribed an antipsychotic drug, and over 7 in 10 of those prescribed antipsychotics had no record of severe mental illness. The discrepancy between psychotropic drug use and mental illness recording suggests that these drugs may, in some cases, be inappropriately used in people with intellectual disability. This is concerning, as these drugs may cause adverse side effects, and they should not be routinely used outside situations in which they have proven benefit. Our results highlight a need for strategies to reduce inappropriate psychotropic prescribing to people with intellectual disability. We believe that ensuring people receive the right treatment can be best achieved through a combination of approaches. This will include further research into the benefits and side effects of psychotropic drugs in people with intellectual disability. Alternatives to psychotropic drug use, such as behavioral and environmental interventions, should also be considered. Finally, training of staff and education of patients and carers will also play an important role in reducing inappropriate psychotropic prescribing. A full copy of the paper is freely available at bmj.com.
Okay, so you might ask why did I show that when we're talking about using these medications in our consumers? One of the most common questions I get when service coordinators send me a request to review a medication profile for a consumer is, are they on too many medications? It happens almost every day. This concern might be brought forth by the caregivers, family of the consumer, the service coordinator themselves. So it's just a very common issue for me. And I will look and I will see a number of psychotropic medications. And in particular, people get concerned when there's more than one antipsychotic used. And I would say that in general, we try to not use more than one antipsychotic medication at a time. Given that, though, if you look at practice guidelines, they will say to try one medication. If that doesn't work, then try another medication. But ultimately, as you go down the list of options in those guidelines, you eventually do come to a place where they talk about the possibility of using combinations. The problem with combinations is that there are not a lot of data to suggest that doing that works better than simply trying another agent, single agent, that hasn't been used before. So it's a common question that I get. This video points out that there's some concern about that. So it is something that we watch our consumers very carefully for. And as I say, people can send me things to review and we can see what we can do to find out if something could be done differently or could be done better. So I just wanted you to be aware of that. Okay, so now, what are some of the concerns that we have in using these in the developmentally disabled? Well, we do see psychosis and psychotic disorders in our consumer population, but it's not the only reason that these medications are used. So if they're being used for other conditions that are off-label, that could be a concern. We're concerned also when too many of these medications are used by the same consumer. Certainly, 2 might be reasonable at some point if multiple trials of a single agent haven't worked. Some patients do better on a combination, particularly if the pharmacology is slightly different on these medications. When you get to 3, the evidence suggesting that 3 are better than 2 is really very skimpy, if there's any at all. But nevertheless, you can get more side effects by doing that. So we're very concerned. We want to watch these drugs very, very carefully. They can be used in certain situations of aggression and behavioral disturbances. However, as was pointed out in that video, there are behavioral things that we can do and should probably be tried first. And when those don't work, then we can consider the medication. But keeping the consumer on these forever may or may not be appropriate. So in other words, you want to, if you're having some sort of behavioral disturbance, whether it's aggression or acting out or whatever, you want to do a thorough examination to find if something else is causing that. What's changed in the environment? Has there been a physical change in the consumer? Has his health changed? You want to explore all of these things before you simply put them on an antipsychotic and keep it there forever. There should be a periodic reevaluation of the antipsychotic. Does it need to keep going? And for instance, at the annual reviews for our consumers, this needs to be a consideration. Does the person still need the antipsychotic? Because there may be in this population, as I said, a higher sensitivity to some of the side effects with these medications. But certainly there's also a concern of drug-drug interactions. Many consumers have 10 or more medications on board, and then you get various types of drug-drug interactions. They can be additive effects. They can be one offsets the effect of another. They can be that one drug inhibits the elimination of another drug, increasing its level. There's just a number of different types of drug interactions that can happen, and the more medications you have, the more likely you are to see those drug interactions. And so in general, in the developmentally disabled, unless you have a specific indication for using one of these drugs, we typically would encourage people to try non-drug approaches for behavioral problems or disturbances. And then if those things don't work, we can add something like an antipsychotic, but do it with specific goals in mind, determine if those goals are met, and then there's ongoing monitoring to see if the medication is still required. You don't just put them on it and leave them on it for the rest of their lives. You need to do periodic assessments. Now, what do we generally see improve when we put consumers on these medications? Well, obviously, we hope to see psychosis improve. So if they're having hallucinations or delusions, we want to see those reduced. You may also find that the consumer calms down, particularly if they've been aggressive or acting out, those kinds of things. In certain patients, they may be used again to augment depression. So if they're being used, let's say that you have Abilify, the generic name is aripiprazole, being used with, let's say Zoloft, which is the generic name, sertraline. You've got an antidepressant, and then you've got the antipsychotic Abilify to augment that. You would expect to see the depression improve. Thought disorders should improve. And then with autism, you may see irritability improve. There's some of these meds can be used in that population and actually are approved for treating irritability with autism. Now, again, I know I'm talking a lot about side effects, but these are some serious psychotropic drugs. And so, again, the first generation drugs are more likely to cause some of the things like constipation, dry mouth, tardive dyskinesia, extrapyramidal side effects, depending on which one of those drugs you're talking about, compared to the second generation agents. So they do differ, these two classes, first versus second generation drugs, in terms of side effects. But as I said before, each person kind of responds on their own, the way their body decides it's going to. So there's some of these medications that can cause really significant weight gain, and there's some that don't cause much weight gain. But the fact of the matter is, any individual agent, even if it has a low risk of weight gain, there will be some people who put on weight with those medications. So it's always an individual thing, and you always monitor the consumers closely. There are some common, what I would call common non-serious side effects that you don't have to worry too much. Sedation, if it's just a little sedation, it's not increasing their fall risk, it's not making them lay in bed all day, and probably that's more of a nuisance than it is serious. But then there are potentially serious ones. I've mentioned tardive dyskinesia. Also, with the second generation antipsychotics, metabolic side effects like hyperglycemia, an increase in blood glucose, changes in the blood lipid cholesterol panel could be serious problems that you see with these. And again, as you combine psychotropics, the more likely you are to see some of these side effects. So the bottom line is, for those of you out there who are working with our consumers who are on these medications, it's just really important that you monitor them for us, actually, because you're with them every single day. And whenever you see something, it needs to be reported, and whoever the treating prescriber is, healthcare provider, should be made aware that you think there may be a problem with this medication. So here's a listing of some of the more common problems. I don't want to go through all of these. Some of the more common ones that I do see are constipation, because many of these drugs have what we call anticholinergic properties that can also dry out your eyes and make your vision blurry. Endocrine problems can also happen. These drugs can cause an increase in prolactin levels, and that can lead to amenorrhea or breast enlargement. In terms of the central nervous system, we see a lot of sedation, particularly in consumers who are on a number of medications that can also cause sedation. We typically see that. And another thing that I want you to be aware of from a cardiovascular standpoint is that some of these drugs can cause what we call postural hypotension. And what that means is as the patient arises, the blood pressure drops and they can actually pass out if that happens. So you want to watch their blood pressures. They can change heart rhythm. And generally that would be seen on the electrocardiogram. So that would be done actually by the prescriber and should be done periodically just to look and make sure what impact this has had on the ECG. But in particular, you want to watch for drug interactions, because if you have multiple drugs that can have this impact on the heart rhythm, then we need to be very, very careful and make sure we are watching the electrocardiogram. Other things, any drug that you give a patient can cause a rash, but sun sensitivity can actually also be a problem. And also maintaining body temperature can dysregulate maintaining body temperature. And some patients can suffer problems with heat more likely if they're on these medications. Other things, neurologically, I've mentioned what we call extrapyramidal side effects. That's some of these movement problems. They get stiff, or they have an abnormal, like sometimes you can see their eyes roll up, or difficulty swallowing. These things are called extrapyramidal side effects. Parkinsonism looks like they have Parkinson's disease. Their gait may slow down. They have a shuffle. They may have what we call cogwheel rigidity, and that is where they get rigid and don't move as well. We mentioned akathisia. Dystonic reactions are abnormal muscle contractions, and that can be very, very painful. Can be associated with restless leg syndrome. So there are a number of these things that you just need to watch your consumers closely for. Now, I've mentioned with the second generation antipsychotics that there can be these problems with metabolic parameters. Weight gain is fairly common, but again, it differs between the medications. On the high side of causing weight gain, you have clozapine and olanzapine. And then you get to the middle section with risperidone, which is Risperdal, quetiapine, which is Seroquel. Then you get out on the less likely end of the spectrum with aripiprazole and possibly ziprasidone. So again, it can occur with any of these drugs, but the propensity to do it may differ with the medications. Lipid abnormalities, you can see increase in triglycerides, changes in the lipid panel. Again, more likely to be seen with clozapine, olanzapine, less likely with the other drugs. Diabetes, you can see increases in blood sugar and the development of new onset diabetes with these drugs. They all can do it, but again, it's highest. In general, all these sort of be highest with things like clozapine and olanzapine, lowest with things like aripiprazole, et cetera, on the other end. Each one has its own propensity to cause it. But we watch all patients for it. And so the American Diabetes Association has recommended monitoring. And in fact, I do this every morning in our hospital when we have patients who are newly admitted on these drugs. I make sure that we have a fasting blood glucose or an A1C, lipid panel, body weight, waist circumference, BMI, those sorts of things, in order to know where they are on this metabolic spectrum. And we want to be able to deal with it because we obviously don't want to create diabetes. So again, this is just a picture showing the propensity of the agents to do it. But I want to make a strong point again that any of them can do this. Some of them just have a lower propensity to do that. So how do you mitigate this metabolic risk? Well, one is you want to do consistent monitoring of their appetite and their body weight and then the BMI. And we try to encourage patients as much as possible who are ambulatory to move around and also think about their diet. What are they eating? We want them eating a heart-healthy diet. We want them eating less simple sugars and more complex carbohydrates. Just eating a heart-healthy and diabetes-healthy type of diet. Want to do regular monitoring. Occasionally do fasting, serum lipids and cholesterol, blood glucose, those kinds of things. So we talk to our patients about a healthy lifestyle. Now, I recognize that in our consumer population, their ability to ambulate or exercise or move around is going to be somewhat limited. So we have to watch them fairly closely. And if you see any, for instance, if we start a consumer on one of these medications and all of a sudden you start seeing them put on weight, you need to alert the prescriber so that perhaps that medication can be reconsidered, because most of them will have similar therapeutic effects. So when they start having kind of these weird side effects, they can be changed around to one that has a lower risk of causing that. Now there are what I would call some rather serious side effects that we have to be careful about. One is a decrease in white blood cells. And while all of them can do it, the one that's most likely to cause a serious decrease is clozapine. And that's why every consumer who happens to be on this medication has to have regular blood testing, and they're looking at the complete blood count to specifically look at what's called the absolute neutrophil count. That's a certain type of white blood cell. And if that decreases too much, you're very susceptible to infections. It's very important that we have our white blood cells to fight off infections. And if we deplete them too low, even antibiotics are not going to be completely effective for us. So this is very serious. Clozapine is the only one that has a requirement for monitoring the blood. If you don't get the complete blood count and the absolute neutrophil count, the pharmacy cannot dispense the medication. It's essential. When you first put the patient on it, it has to be done weekly. As they progress and they're tolerating the medication, it can be switched to monthly and then a little bit less frequently later on. You can also see a increase in the risk of seizures. All of them can do it. Again, clozapine is one that we have to be very careful about. Neuroleptic malignant syndrome, fortunately, is a very rare but serious side effect, and it causes dysregulation in body temperature and blood pressure and contraction of muscles and some things like that that can be very serious. Unfortunately, it's rare, and I, in my own practice of over 30 years, have not seen neuroleptic malignant syndrome. Cardiac arrhythmias can be a problem. As I said, these drugs can change the conduction in the heart and can make ventricular arrhythmias more likely. You can still see tachycardia and things, but ventricular arrhythmias are very concerning, and we have to watch out for those. And we watch out, especially if they're using combinations of these agents that can do it, or if they're given to patients that already have conduction disorders in their heart. As I mentioned, hyperthermia can happen. Temperature regulation can be compromised in some patients if they're taking these. Precipitation of glaucoma and priapism, which is a prolonged erection in males, and some of these metabolic problems. So those are what I would consider serious side effects that we have to watch out for. Now, in terms of neurologic side effects, which are fairly common, as I mentioned, there are these extrapyramidal side effects, kind of dystonic sorts of things that can happen. And you see stiffness and rigidity, problems swallowing, Parkinsonism, can be seen as a pill rolling tremor, a shuffling gait, slow shuffling gait, not much expression on the face, difficulty balancing, and those are fairly common. And they're more common in drugs that are more potent, that block those dopamine receptors. And so again, the propensity to cause this differs among the different antipsychotic agents. There are some that are very high risk. For instance, haloperidol is a fairly high risk drug for causing extrapyramidal side effects. On the other end of the spectrum, drugs like aripiprazole are less likely to cause these, although aripiprazole can cause akathisia. Some of the dystonic things and the slow shuffling gait are less likely to occur with that drug. So if they occur, we have two things that we can do about it. We can give patients an anticholinergic medication. We'll typically reverse these extrapyramidal side effects, or we can switch the drug to one that's less likely to cause it. So I wanted to also show you here, get my link. I wanted to show you what these problems would look like. Let's see here. Oh, wrong one. Let's see if we can stop this.
Hello,
All right, let me go back and start over. I apologize. As I said, I had this all loaded up, unfortunately.
The things that I think get missed most in the psychiatric population are the slowness and the change in their walking and their posture. Most schizophrenic patients who are treated with neuroleptics don't have significant walking problems or balance problems, even though you may see that they're a little bit stooped and they don't swing their arms so much. Try not to lose your balance. And they may be a little slow, but it doesn't really interfere with their activities all that much. But I'm going to do it harder. And in a sense, you can understand it. If their psychosis is under control and the patient's not complaining about something, terrific. Leave well enough alone. Why rock the boat? But I think there's a lot of Parkinsonism that goes on that's just not recognized. Or if it is recognized, people say, well, that's the price you have to pay in order to get adequate psychosis control. Do you ever have tremors? Do you ever notice that you shake?
Yes. My thighs shake a lot, and my fingers shake a lot.
Okay, does that bother you much? The other problem is that they're often not able to supply history.
A little bit.
They often tolerate drug side effects because they've lived with them for 20 or 30 years. And I think they probably just shrug their shoulders and say, this is part of what's wrong with me. Plus, they've been treated for so long, and the development of these things may be so gradual that they don't perceive them. You take a drug, and all of a sudden your head twists like this. You know about it. You say it's the drug, very clearly identified. But you develop Parkinsonism, which develops over days, weeks, or months, and people don't know it. They notice when they have a tremor. So if their hand's going like this, they'll say, oh yeah, I shake it from my medicines. But if they're like this, and they move slowly, their balance is a bit off, they won't recognize that. And frequently their doctors don't either. They all recognize the tremor. But beyond that, they frequently don't identify the other things, the stoop posture, the absence of arm swing, and the bradykinesia. Those often go unrecognized. Now, with the right hand, go like this. This fellow has facial masking. Can you hold it sideways now? There you go. He has diminished, and this, he's not much older than me, and that would be normal. And the left hand, you see, he's very, very bradykinetic. Okay, put your hands down. Up and down, whole leg up and down. He's tapping his leg up and down, and he should be able to get a much, much higher amplitude and better speed than he's generating right now. So these are manifestations of his bradykinesia. Careful with your head. I want you to come out in the corridor. One of the issues that I face relatively commonly is, like him, the issue of a person who's being treated with an antipsychotic who develops Parkinsonism. And the question then is this purely drug-induced and will go away completely, never to return if they're taken off the drug? Or is it Parkinson's disease, sort of unmasked prematurely by drugs that do that, like the typical neuroleptics and risperidone, and to a lesser extent olanzapine? So I can't tell whether he might have underlying Parkinson's disease, but it did get better off the olanzapine. Back into the room.
Now, psychiatric patients can be visibly affected by their antipsychotic treatment. And I don't want my patients to look like they're on antipsychotic medications. We talked about your concern about the medicines you were on, that you would look medicated in these interviews. Could you tell me about that? What's the concern about that?
I am afraid that I'm not expressing a full range of emotions, that I look kind of rigid, that I look kind of medicated, and that people can tell that there's something wrong with me, you know, just by observing me.
One of the terrible things about EPS is that it brands you as being on medication.
Well, it's kind of an unemotional quality about it, you know, a lack of animation.
And the meaning of EPS is that they're visibly stigmatized by the side effects on medication.
Right.
Just imagine what compliance to AIDS medication would be if you took a protease inhibitor that gave you some sort of physical side effect that made everyone know that you're on a protease inhibitor for your AIDS. I mean, think about that. Now, if you have a side effect that saps you of your energy, that may not be a problem when you're an inpatient and you're just going to groups or OT and you're not really stressed or taxed. When you are then discharged, that mild Parkinsonism will turn into major Parkinsonism.
Turn around, do it one
even
more
if the
time.
side effect hasn't changed, because the person's now back out in the real world and has to get a job.
Turn around.
So it's a major problem.
Do you have any problems with slowness? Okay. Do the letters of the alphabet. I just want to hear how you talk.
A, B, C, D, E, F,
So
G,
a mild Parkinsonism on an inpatient ward turns into a severe Parkinsonism for the patient when their functioning improves.
creatine, poor performance kit.
The approach to treating these patients is to put them on an antipsychotic if they need one, which doesn't cause Parkinsonism as a side effect, or which doesn't worsen Parkinsonism if the person has Parkinson's disease.
Put him in the G building, and I was into the story.
When you were counting off on your fingers, your shaking stopped. Did you notice that?
Yeah, when you hold your hands together and you put your hands in a lock and hold it like this, it might just shake out the tips, but it'll basically happen when it stops.
There are only two drugs that don't worsen Parkinsonism, which are Clozapine and Quetiapine. That, to me, is the treatment of choice. You might advocate using either an anticholinergic or a mantidine.
3 times a day.
But if you have a drug that causes side effects, the best choice is to get rid of the drug that causes side effects rather than to add on yet another drug to counter those side effects and then contribute new side effects from the new drug. So it makes sense to try to transfer that.
Okay, so you saw what it looks like, and at the end he made a sort of a quick comment about what do you do if you see these extrapyramidal side effects. One is, if you can, you stop the drug, but many patients will not do well when you stop the drug. So the second thing you might try is to try an agent that's less likely to cause the extrapyramidal side effects. And as he pointed out, very low likelihood with either Clozapine, the brand name is Seroquel, or Clozapine. The problem with Clozapine, I've already mentioned, is you have to do the blood testing, and it can cause serious problems with your white blood cells. So many people would not do that. But another option would be to switch to an agent that has a lower likelihood of causing it. And you may find that the patient doesn't develop extrapyramidal problems with that drug. So the point for you guys is I just want you to recognize what these things might look like. And then if they occur, this is something that should be brought to the attention of the prescriber. All right, let's get back to our presentation here. Now, another one that I wanted to mention specifically is akathisia. And this is really motor restlessness, and it may appear as nervousness or agitation or even anxiety. And I have seen it missed in some patients in the hospital because it simply looks like their condition has gotten worse. But in fact, it may actually be akathisia. And so what you see is the person may pace or jog, moving their legs a lot. They may sit and then not do that very long and then stand up and start moving again. And people may not be able to sleep because they can't quit moving. And it can cause an increase in suicidal behavior and aggression in some people with developmental disabilities because it's such an inner turmoil. And that can happen either when we start the drug or within a few days after doing it. So let me show you what that looks like. Oops, let me stop that. So technology is creating issues for me today. No, this is the wrong one. Okay. Wow. I'm really having trouble today. I'm sorry, you guys. This isn't working like I thought it would. Okay, so you see how he's constantly in movement? That's the issue with akathisia. So notice how he's constantly in movement, constantly in motion. Okay, now another problem that you can see with these agents, and this one actually can be really a serious problem for patients, are what we call dystonic reactions. And those are sustained painful contractions of one or more muscle group. And I've seen that with, for instance, a tongue just sticking out. The throat can close up. I actually had an emergency happen at the hospital where a code blue was called for a patient that was in the cafeteria eating who'd fallen over, and it looked as though he was choking. And when we got there, turns out he was not choking, other than the fact that his muscles in his throat had tightened up so much that it actually closed his throat. We gave him a quick injection of a medication that would reverse that. And it was over with like within a couple of minutes. Other problems, you can see upward deviation of the eyes. You can see torticollis, which is where the head kind of goes back, looking over towards behind you. And like I said, oculogyric crisis, where they just get frozen up, the eyeballs get frozen up there. Often happens right after the medication is taken. More often seen early, but can happen anytime during treatment with these medications. And in severe situations, for instance, with this closing off of the throat, it could be actually a very serious life-threatening side effect. So now if I can be a little bit more creative here with getting this hyperlink open, and for you, I'll show you what it looks like.
So when did you start having trouble talking? Early this morning? And did you take any drugs? Other than your prescribed drugs? No? You don't do cocaine or anything like that? No? Okay. Count to 10 for me.
1, 2, 4, 5.
Okay, that's good.
I said what I want to say now.
Right.
I feel better. I am glad I can see you all.
Quick question. Has the pupil on this eye, has it been bigger than the pupil on your other eye for a while?
Yes,
it has. Okay. Okay. Has that ever been ever since you had your head injury? Yeah? Okay. Still want to spin the head?
Let's talk about it. Count to 10 for me now.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
All right.
Oh, no, sorry.
Now he's hamming it up.
I feel better.
Now your voice isn't perfect, but is this how you normally talk?
No.
Not yet. Not yet. Yeah, but your speech is still a little slurred.
Because I had this turkey.
Okay.
But the doctor said, give me some Benadryl, and the doctor knew exactly what the purpose was. The purpose was to give me some Benadryl, and that's what they did for me. Give me some Benadryl.
Now, are you talking back to normal for you? Is this how you talk?
Yeah.
Okay, all right. So you had some traumatic brain injury sometime in the past, is that right?
They killed my brain.
Okay, and so, but you have some psychiatric issues too that you're being treated for.
I be having
flashbacks. Hey, so you have your right guard over there, and sometimes people actually huff that to get a high on it.
What?
Yeah, but were you using the right guard at all?
No,
you weren't.
I didn't use it for deodorant.
For deodorant, that's using it like it's supposed to be good. Okay,
yeah.
Well, you're very kind to the rest of us. That's thoughtful.
You're very kind too, and I appreciate you for helping me.
All right, you're welcome. You're welcome.
I knew when I was speaking this morning.
Okay, so that was a pretty dramatic presentation, and this patient had been taking risperidone, which is Risperdal, and you can see it was very dramatic, that dystonic reaction. But also, by giving him 50 milligrams of Benadryl, they gave it IV. We can also give it intramuscularly. We can reverse these things very, very quickly, and you can see the dramatic difference that it makes. So this is something we want to have you watching consumers for when they're taking these medications. Now, another problem that can occur is tardive dyskinesia. And as I said, that's an involuntary muscle movement situation. It's usually after usually several years of therapy, at least 6 months of therapy before we would consider making that diagnosis. And the real seriousness here is that it can be progressive and it can be permanent. If you're lucky and you see some symptoms and you stop, maybe it goes away. If you're not so lucky, you stop the medication, it can actually get worse. You increase the medication, it gets better, and then it comes back. So it's a very serious side effect, which we try to avoid as much as possible. And what do you see? You see lip movements a lot up in the orofacial area, lip smacking, tongue protruding, puffing, blinking, and some of these kinds of things. I'm actually going to show you some pictures of this in a moment. But these are things that the patient cannot control. They're involuntary movements and they can't. And if it goes on, it can progress into some very serious disability for the patient. So it's something we want to be very careful to watch for. And I just happen to have a picture for you of it.
Photographer. Wait, stop. All right, now do it again. Start over.
It started a year ago with my tongue jerking back all the time, but it progressed pretty quickly within about 3 or 4 months. Okay. It's gotten worse. Okay. This has gotten worse since I've seen Dr. Truck. Oh, really? I now have a stutter and I now have this kind of a more complex set of movements around your mouth, it looks like. Yeah, well, the inside of my mouth right here hurts from my teeth. You know, yeah, pretty frustrating problem. And the stutter's pretty bad. Okay. And how much problem with eye closing? Any of that? None of that. Okay. And she does have, I remember, I'm sorry, I'm so kind of getting to know your situation, that's why I wanted to touch base with you. And her past medication history, she does have something that, Reglan or something that would be a liability for this type of problem? Geodon, okay, all righty. Said to be less common with this, but I guess that's right, I did see that Dr. Truckman's note. But it's not zero. And there have been more and more cases reported. Is that right? Like year or two. Okay. Yeah, to the FDA. Okay, and they do tell they tell us when we prescribe these medicines that they can't say that it's a zero risk. It's certainly less than the older medicines were. Well, how much benefit did you get from the Artane? Would you say percent wise? Well, see, we're only starting with half twice a day. Right. And then starting today would have been half 3 times a day. Oh, okay. So we're just getting. But I can tell you that the way it's changed my life is that it's made me able to perform my daily functions. I mean, I was beat by the other 2 men. Okay. By the Clozapine. Not really. The Ativan, after just a few days, was not sedative, but the effect would wear off after about 2.5 hours. So by like 4 in the afternoon, I would have taken 3. Okay. And we didn't want to take more because I was scared to ever take more. Right. So then we tried the Clozapine, and that only lasted about 4 days. But for first pill that I took, I fell asleep for like 5 hours. Yeah, that really do that to people. Yeah, so then I tried taking half, 3 times or whatever instead of a whole month, and I still wasn't like I couldn't drive. Okay. And stuff. So I called Bob, and that's when we tried the Artane starting Saturday. And even though we're just still ramping up, I can tell that it's gonna be it's pretty darn effective. I would say that even at the low dose I'm at, it's probably 50%. Oh wow. Yeah. Okay, so you're less of the involuntary movements and less of this friction on your inside of your lips and all that. Well, that's very encouraging. Now, the Ativan was so effective that the movements rarely happened. Okay. But instead of it lasting, say, 5 hours like originally, after a while, I was only on it maybe 4 weeks or something. The effectiveness was like 2.5 hours. Oh, okay. So you're really short. Know how addictive. It's habituating, and that's so you get the same. You get habituation to the benefits as well. So, well, I'm very encouraged because it'll be a lot if we can find a medication that can help reduce this, and maybe something like Ativan if you have flare-ups or situations in which it may form a problem like a as needed more type of thing. That might offer you the best benefit because we use Botox for these things, but the more complex the movements, the harder it is to get full control with the Botox because we can't do all of these muscles. And the external facial muscles, it's easy to overdo it because you can get droopy on one side of your mouth, have food fall out of your mouth and such. People don't generally like that. And then the opening part, I'm currently trying to work out a plan for taking care of that with someone from the head and neck surgery group. Because as Bob may have told you, the person in our department who did injections for the jaw opening is no longer here. And
okay, so now you can see what that is and why it is such a problem for patients when it occurs. A couple of interesting things. I know the audio was a little bit low on that, but they mentioned that she had been taking Geodon. The brand name is Iprasidone, and that's actually one of the ones that's less likely to cause tardive dyskinesia. But as you heard her say, they can never say they're 0%, and somebody may end up with this reaction. The other thing to have noticed on that video was that there are a number of different medications that we can try to improve it. Some people may do well with those and some may not. And, you know, they mentioned Clozapine, they mentioned Ativan and Artane. Some of these medications can be tried, and if it works, great, but if it doesn't, then you're faced with a dilemma. What do you do? And sometimes in severe cases where the antipsychotic is still needed, they might switch the patient to Clozapine, which is an agent that has a low risk, very low risk of tardive dyskinesia, but may still control the psychotic disorder. Now, how do we monitor for this? Well, obviously for you, the most important thing is that when you're working with consumers is to notice if there are any of these abnormal involuntary movements that you can see. And if there are, then you need to alert the prescriber and have the consumer evaluated, because again, early intervention is a really important aspect of care here. Another thing that can be done is, as I mentioned before, is a scale called the Abnormal Involuntary Movement Scale, or the Ames scale. And I want to show you briefly, I may not go through the whole video here because I know we're pushing our time limit, but I wanted to give you a brief picture of how this might work. It's not that I want you to be able to do the Ames, but I want you to be able to see what it looks like, because you may see it used at some point.
It may be useful to think of the Ames examination as having two parts, one informal and the other structured. The Ames examination is scored by observing and rating the severity of the abnormal involuntary movements in 7 different body areas. A scale of 0 to 4 is used. 0 is used when no movements are present. 1 indicates minimal involvement and should also be used for movements which may, in fact, be extreme normal. 2 is for mild movement. When the informal observations have been completed, the structured portion of the examination can start. Since standing over a patient may make him uncomfortable, it's best to sit next to the person. This allows the examiner to easily demonstrate the required movements. This is an appropriate time to discuss the purpose of the examination. Your description should be brief and to the point. Excess explanation may only serve to increase anxiety and confuse some individuals. The first step of the Ames examination requires the examiner to ask the patient whether there is anything in their mouth, such as candy or gum. If there is, it must be removed. Second, ask the patient about the current condition of their teeth. For example, does the patient wear dentures? Do teeth or dentures bother the patient now? Patients with tooth or gum disease may develop oral movements which mimic those of tardive dyskinesia. Dental status becomes important when trying to make a differential diagnosis. Instruction 8 of the Ames examination has the patient tap their thumb with each finger as rapidly as possible for 10 to 15 seconds. Do one hand at a time. The primary purpose of this exercise is to distract the patient. Due to the concentration required to perform the exercise, previously suppressed movements will frequently appear. The examiner should not be concerned with how well the finger tapping is performed, but instead should look for any facial or leg movements precipitated by this exercise. Do not score mirror image movements of the opposite hand. Please note, item 8 is often referred to as one of the activated movements. Some examiners score this portion differently. This scoring variation will be discussed in a few minutes. Mentally score each segment as you view it. Near the end of each piece, the correct score will appear in the lower right corner of the screen. This is the score of a practitioner panel. The segment number appears in the upper left corner. Remember, abnormal involuntary movements are scored from 0 to 4. 0 denotes the absence of any movements. 1 is minimal. It may be useful to think of 1 as extreme normal, movements which are borderline. 2 is mild. These are movements which are decidedly not extreme normal. The person obviously has some degree of abnormal involuntary movements. 3 is moderate, and 4 is severe. This segment features a rather subtle lip movement. Notice the sucking in the lower lip. You may think this movement is minimal and give a score of 1. This would be too low. Remember, 1 is used for borderline movements, movement which may actually be extreme normal. This movement is too persistent to be extreme normal and should be scored 2. The patient in segment 10 has constant jaw movement. Notice the frequency and amplitude of the movement does not change. It is the same before, during, and after the activating exercise of extending the arms. This is a good example of why a point should not be subtracted when scoring movements detected during an activating exercise. Segment 11 is quite short and will be shown 3 times. Notice the increased frequency and amplitude of this woman's jaw movements compared to the previous segment. The fourth body area to be scored on the Ames examination pertains to the tongue. Pay particular attention to whether the tongue breaks the imaginary vertical plane connecting the upper and lower teeth. This automatically warrants a score of 3. Segment 12 shows a borderline tongue movement. When this man opens his mouth the second time, there is a quick jerk of his tongue. That portion is shown twice. Without further observation, it would be difficult to justify more than the minimal score of 1. The jerky movement observed may only be extreme normal. This segment illustrates a mild movement disorder. Sufficient movement is observed to rule out extreme normal. This woman is attempting to stick out her tongue. It is not uncommon for patients to have difficulty with this maneuver. A mild movement disorder is obviously present.
Okay, so that shows you how we can measure this, but also it was there were some good examples of how some of these movements might look like if you see them in consumers. And again, it's very important that you help us monitor for these. So let me get to the bottom line here. How can you help with our consumers? You obviously want to observe them when they're taking these medications. And you should know what the movement problems look like. They're the acute ones, like we saw the dystonic reactions, we saw other extrapyramidal things, we saw the akathisia. Those are things that you should be watching for. But in terms of the long-term use of these medications, think about those abnormal involuntary movements that we just showed you, particularly some of the facial movements and the tongue and those kinds of things. And if you see any of that, you should let the provider know so that the person can be evaluated. And if you see any of that stuff, you need to report it obviously to your site director and to the service coordinator. Now, there's something that's not on this slide that I want to ask you to remember to do. And that is when we have patients who are started on these antipsychotic medications in addition to watching for potential side effects, I'd like for you to watch for potential therapeutic benefits. Because remember, we start these medications and we should have some target outcomes that we're expecting and that we watch for. And so, for instance, if you're starting them for psychosis, then we should see a reduction in whatever it is, the hallucinations or delusions. If you're seeing these used for behavioral disturbances, again, we hope that there are going to be some behavioral things done first, but if you see them used, then there should be some very clear behavioral targets that you're going to help us watch for. And if those don't improve, you need to let the provider know. It could be a dosing issue, it could be an ineffective drug issue, but the point is watching them for therapeutic effectiveness so that we can know if the drugs are doing what we expect them to do. If the drugs are not doing what we expect or they're causing side effects, then we need to reevaluate whether or not the consumer should be on those medications. And again, if you have any questions along the way about your consumer's medication profile, you can always have the service coordinator send that to VMRC, to my email, which is pharmacist@vmrc.net, and we can take a look at what's going on. Now, as we said, a quiz is going to be made available. I sent it actually to Lorraine, but now, as Claire pointed out, we're going to send this to Vicki Fisher, and her email is going to be vfisher@vmrc.net. And you can always, if you need to, send something to me at pharmacist@vmrc.net. And Vicki will make that quiz available to you. And as I said, just get those answers back to her and then let her know how you want to have the certificate. So again, I want to thank you for your attention. I apologize that I had my browser closed up when I should have had all those YouTube videos loaded up ahead of time. We will do it better in January. Keep an eye on the VMRC site. We'll be setting up our new schedule for classes that will start again in January. And if you have any questions, I'm at pharmacist@vmrc.net. I wish you all the very best holiday season, and hopefully you'll stay safe and healthy. So have a great day.
Thank you, Dr. Kehoe.
Hey, Claire, did you have any questions that were sent in?